Welcome back to Beyond Well Science. I'm Sheila Hamilton, and I am so pleased to be here today with Keris Myrick. In her career, Keris has been the chief executive of Project Return Peer Support Network. She's also been the chief executive of NAMI, the National Alliance for Mental Illness, and worked in both governmental roles and others helping support people with mental health challenges. Thanks a lot for being with us, Keris.
Thanks for having me, Sheila. It's such an honor. Thank you so much.
I think most people who might recognize your name will probably remember it from the New York Times piece, which was a stunning piece of journalism on a woman who has not only managed to live with a very serious mental illness diagnosis, but thrive in the workforce. Could you tell us just a little bit about why you decided to participate in that New York Times article?
Yeah, sure. When Benedict Carey approached me about the series that he was writing and asked would I be one of the people to be covered, the first thing I did is ask my dad about it because I really thought it's important to help the general public understand what it's like to live with a diagnosis of schizophrenia or schizoaffective disorder. I get kind of two different diagnoses depending on who I talk to.
Yeah.
And then also, I did want to talk about the support of my family, and at the time, my mom had already passed away, so I did want to talk about the support that I had received from my father, and if I was going to talk about my dad just as if he were going to talk about me, I would hope that, he would ask permission to do so. So I asked his permission, and the most important thing for me also as a woman of color was to be able to talk about what it's like as a person of color, as an African American, to talk about living with a diagnosis of being given this diagnosis of a serious mental illness, so that other people who look like me could understand that and see the evidence that recovery is possible and kind of what it takes. It takes a lot of work.
No kidding. Keris, one of the most stunning parts of that was your realization that sitting in a diagnosis and being told that your life is got to be very limited and you can't do very much was one of the things that was making you worse. How did you come to that realization that you actually need a very full and challenging life?
I think it has a little bit to do with how my parents also and my brother and the rest of our family held very high expectations for us all, because the world would hold low expectations for African Americans. So, we were brought up, and people of color may know this kind of experience, sit in the front of the classroom, raise your hand, be an active participant in the classroom, kind of break the stereotypical view of what people of color have the ability to do. So when I was told, you'll never, go back to work, you'll never finish school, you'll live at home or in some kind of institutional setting, that was going to be my life trajectory. It was like, wow, I sort of have heard this before in my life.
Yeah.
And it had something to do with being a person of color versus having being given a diagnosis of a mental illness.
I think that's so wonderful that you're likening it to the experience of discrimination, because I really believe that discrimination against people with mental illness is kind of the last frontier of civil rights. And your work, especially the way that you have offered it in this article, it's something I can relate to so much. Keris, thank you, first of all, so much for going public with this and challenging the notion that people with mental illness can't be really productive members of our society. So I know you recently attended the WHO conference, and I want you to talk a little bit about your decision to go there and to be a part of this very influential and prestigious trip.
Yeah, so last month I went to Trieste, Italy, to attend a World Health Organization, World Federation for Mental Health, and Trieste Mental Health Department conference called Good Practice Service, Promoting Human Rights and Recovery in Mental Health. And the reason that I did that was for the very reasons that we just talked about. It is about understanding the human rights aspect of mental health care, mental health, and living with a mental health condition. And I think a lot of times we think about mental health and practices to support people with mental health all around the symptoms and reducing symptoms, when in fact it's really about people and people sitting within a political and economic and community context, a social context, and the rights that are afforded to each person in order to move forward in their recovery. So it was a surprise, I think, a little bit to go and see a conference that was really rooted around the World Health Organization and UN's Convention on the Rights for People with Disabilities, and how that, it's called the CRPD, and how the CRPD is kind of where mental disabilities, as they might call them, fit within those conventions of the rights with people with disabilities.
Yeah.
So the first 2 days of the trip were focused on that.
So talk more to us about what are the critical ingredients of what makes Trieste a model for mental health care and support.
Yeah, so Trieste, Italy is considered a World Health Organization collaborating center for research and training in mental health. And what that really means is that it has an exemplary focus on the rights and autonomy of people with mental health conditions to live free and be free in the community with the treatment and supports necessary to live full lives of their choosing. And I think the critical ingredients that I saw, so after going to the conference, I actually was able to visit different aspects of their programs. Hard for me to call it a system, though they do call it a system. We think of systems as fairly siloed, and there was nothing siloed there. Everything was very integrated and collaborative. But I think some of the secret sauce of it is they have maybe 1% of the people may be committed to involuntary treatment, but when we talk about involuntary treatment in the U.S., we usually think of people locked in some kind of a psychiatric hospital or longer-term facility. There are no locked doors in Trieste. The only door that gets locked is just like you and I lock the front door of something at night, of our houses. That's the only time a door gets locked. Or if it's like a medication room or a file room, then yes, of course, the door is locked. But anything else is open. People can come and go freely. Even in the general hospital psychiatric unit, where a person may be actually committed involuntarily, they are free to come and go during the day, and people may leave and go have a coffee, and they come back.
Wow, incredible.
And it's like, well, we would never come back. We would just keep walking, right? So it's what the people do there. It's a philosophy of people as humans, as working with people in distress, and helping them through that distress and not pathologizing, I don't think, per se, that experience that they may be having.
Karis, this is fascinating to me because I think about the description of what you were going through when you were in psychosis, and I'm wondering if the ability for you to walk out of a hospital at that point could have helped you instead of made you feel so suffocated and actually jailed.
Yeah, it's so funny. When they went through deinstitutionalization in 1978 in Italy with Law 180, they shifted all of their money and resources towards a very robust community mental health. This is in Trieste, community mental health. And, when I think about it, it's like one of the things that they do that I really wish had happened and could happen in the U.S. is that when somebody is having extreme distress because of, maybe symptomology, if we want to call it that, relative to their mental health condition, hospital is not the only answer. Mm-hmm. One of the answers they have is we go meet people in their home.
Right.
And they stay with people in their home to help them work through that crisis in the home. Because a lot of times you go to a hospital, as I did, and I'd come back home, and the crisis would still be there because the crisis was really in my house.
That's
the way
right.
That I didn't have the support to live in my home.
Yeah. So talk to me more, Karis, about peer support and how it works in the system, and whether or not you think it could be woven into the fabric of our community.
Yeah. So in Italy, peer support. Non-licensed folks are actually not allowed to work directly in the community mental health center, so they have these great, what they're called social enterprises, and the social enterprises they call them social cooperatives, my bad. In the
Okay.
U.S., we call them social enterprises, but they're social cooperatives, and the social cooperatives provide opportunities for people to find meaning and purpose within the community, and usually those activities are either led by or collaborated with people, with peers. And peers are people with lived experience of a mental health condition who support another person on that same journey. So it's kind of like a been there, done that, walk in my shoes kind of thing.
Sure.
And they're, even though the social cooperatives are not a part of the community mental health center itself, they are what I would say, if you think of a Venn diagram, that everything is connected. And that's the other thing that secret sauce, I think, of Trieste is that there are no silos. Everything is interconnected, and everybody's working together at the desire of the person who's receiving services. So we don't quite do that in the U.S. We do have peers and peer support. Sometimes they're separate and outside of the quote-unquote mental health system. Sometimes they're within the mental health system. And I think it would be really, really great to see how we could better integrate the use of peer services, not as an adjunctive, but almost as, well, could they actually be leading a team? And in Trieste, that's kind of how it's seen, is in these social cooperatives, they're actually leaders of the supports that people are getting.
So, Karis, one of the interesting things about the system in the United States is that it really makes people with mental illness feel as if they're giving up a lot of their individual license, a lot of their intellect, a lot of their optimism. Does the system in Trieste hope to achieve some of that recovery of those things that may have been stripped from a human being who has been, I don't know if they treat people who have been through the system in the United States, but it occurs to me that one of the reasons it's successful is because perhaps they don't have that deadening effect on people's liberty.
Exactly. I mean, their philosophy is freedom first, and when the teams are meeting to support a person along with the person, it's always about that person's humanity, the whole person, their autonomy, empowerment, and choice, even in the midst of, they might not agree with that choice, or that choice might seem a bit risky. They do their best to allow as much agency or autonomy as the person to make decisions, and then to live with those decisions and support them. So, they do things like supported decision-making. Again, supported decision-making is done in the U.S., but not in mental health. It's usually done in developmental disabilities or intellectual disabilities. So when people have more autonomy and freedom and choice, even in the midst, in times when we think, oh, that's not really the best choice ever, or wow, you don't really have the capacity to make that choice. That's when I think the if you will, the challenge or the battle between the person and the provider comes up. And there's a saying that says, force, no matter how hidden, begets resistance. And that is a human nature thing. So when things are forced upon us as humans, we resist.
Right.
And so I think a lot of times in mental health, that may be seen as the illness or the symptoms is causing the resistance, when in fact it's human nature that's causing the resistance.
Karis, I'm so struck by what you're saying, because I'm wondering if, as a patient who'd gone through the United States system, and then you're witnessing how people are able to evolve in Trieste, were you thinking back on your own worst experiences of being forced?
Yeah, I I was listening to the psychiatrist when some people, who were in our group were kind of shocked, and they were saying, well, what happens if somebody picks up a chair and throws it? We noticed that your furniture isn't bolted down. This was in the General Hospital Psychiatric Unit, of which there are only 6 beds in a town of 205,000 people.
Wow.
They have a psychiatric unit with
Incredible.
only 6 beds. And that's the only psychiatric unit in the General Hospital. But nonetheless, and the psychiatrist was like, yeah, so they throw a chair. What are you getting at? And they said, well, wait, aren't you afraid of people being dangerous? And it's like, well, if they need to throw a chair, we do our best to get out of the way. Now, that doesn't mean that they haven't been sometimes hit or hurt by someone, and they try to understand that as, what is this person really trying to communicate that we are not doing a good job of understanding?
Wow.
So instead of restraining that person, they give space to that person to go through that experience so that they can dialogue, create relationship, and trust. And that's the powerful thing that we don't do here because we're billing on the 15 minutes.
Yeah, exactly. It seems to me, though, that Trieste is a much more one-on-one model, requires much more assistance from families and communities. And with the broken nature of our families and communities in the United States, do you think that this could transfer?
Yeah, I think there's some really interesting opportunities if we're able to really explore those nuggets, if you will, and then figure out how to translate them here. So there are 4 mental health centers in Trieste. They are open 24 hours. Each one of them has anywhere from 6 to 8 beds in them. So their beds are actually diffused, if you will, in the community with all of these robust meaning and purpose and life supports around them, including affordable housing, group housing, and independent living. So if we started, I think, in the U.S. to think about kind of Venning all of these things, I'm a big fan of circles and Venn diagrams. So,
right.
So that we reduce the silos and have people really collaborating, and then also thinking about, well, wait a minute, the mental health system can't do it all. It's impossible. But, I go to the coffee shop every day, and I see people experiencing homelessness outside of the coffee shop every day, and I notice how the staff in the coffee shop will come out and talk to the people who are experiencing homelessness. They'll make sure that they have a cup of coffee or a cup of water. They would let them use the bathroom, etc. So that the coffee shop in and of itself is part of the solution. So everybody in the community can be part of the solution, and that's going to take a really interesting new way of thinking, that it doesn't get shuffled off over there to that mental health center.
Right.
But it's actually the community is responsible for the health and well-being, including the mental health of each and every one of its community members.
Yeah, I love that. It's like not on my block, the NIMBY thing. We have to begin thinking about that in terms of people in our communities who are suffering from mental health disorders as well.
Well, not on your block, it is on your block.
Yeah, that's right. You bet it is.
That you might not know it. If 1 in 5 people are experiencing some kind of mental health condition in their lifetime, you bet your bottom dollar, unless you live on a block of 3 people, it's on your block. Yeah.
Good point. I also just want to talk to you about how you're doing and how you manage what other people said was going to be this really limiting diagnosis.
Yeah, well, I'm doing great. I mean, I think that, my secret sauce, and everybody has their own, and, it's the journey of recovery is finding out what works for you as an individual, which, of course, makes recovery kind of hard to measure. But at the same time, I think for me, people thought not having a busy life and sticking to a routine and not having a challenging job would be what would work for me, because that's what works for people with this diagnosis of schizophrenia. But quite the opposite is that for me, and again, I'm speaking, for me, that, having a job or work or career that is very challenging, that is like solving problems every second of the day, that keeps me engaged in not just the work, but also the people, and then having a strong support system throughout, this whole process is really what has helped me and figuring that out. And I had that epiphany one night. It was like the middle of the night. I called my mom and I said, "Oh my gosh, Mom, I've had this epiphany," and I was crying. And my mom's like, "Oh my gosh, she's crying, she's sick." And I'm like, No, I'm not sick. I'm actually very well, and I think I figured it out that I need to have a life that is full of meaning and purpose, and I have to define what that meaning and purpose is for me. And what I need from you and Dad and Kyle's my brother, and my family is to support me in that meaning and purposeful journey. And they have done that, no holds barred. It's been amazing. I'm very lucky.
I'm so struck by, Karis, is how many young people that are suffering could benefit so greatly from this conversation with their parents. That they might be able to avoid the kind of institutionalization and heavy diagnosis and heavy drug regime that so many kids are on if they just were open and honest about, I think as a human being, here's what I need right now.
I think if we really thought about HIPAA, for example, that gets thrown up as a barrier, if we started to see HIPAA as a supportive document to help figure out what information do I need as the client, patient, person receiving services to my supporters. And each supporter might need a little bit different information so that they can help me through this journey, and then to visit that the HIPAA policy and paperwork often with family members and other supporters, because I think if we start to see it as a recovery document, it will also serve its purpose as a privacy document.
Oh, man.
Rather than when we see it as a privacy document alone, especially when you're in the hospital and you're brought in by the police or you're brought in under circumstances that are not of your own being, and then somebody asks you to share information, your answer is going to be no. And that no is your power. It's the power that was taken away from you that you're trying to hold on to, so you say no. And what we're trying to do is get people to say yes, and the yes is, who can help you at this moment during this time, and what information would you like them to have? That's the HIPAA question.
Keris Myrick, what a fantastic conversation. I have enjoyed talking with you so much. And if you enjoyed the conversation and you want to become a sustaining member, click on the link right now for the Foundation for Excellence in Mental Health Care. Karis, thanks again. Really appreciate your time.
Thank you, and I'd like to thank the Foundation for Excellence in Mental Health Care and OSF for supporting my trip to Trieste as well. Thank you so much.